Welcome.
Okay, thank you very much for your time. Can you hear my voice?
Yes, we can hear you.
Okay, thank you for the time. Assalamualaikum. Good evening, ladies and gentlemen. My name is Adam Mulyono. I'm a young endoscopic spine surgeon. I live in Yogyakarta, Indonesia, 600 kilometers east to Jakarta, the capital of Indonesia. Thank you very much for Dr. Yaki Vicensko and also ISUBE, Unilateral Biportal Endoscopy International Society, for inviting me. I will represent my presentation. We have talked a lot about a technique, surgical technique, and also the tips and tricks. Now we are take a break, and we are talking about the operating cost of uniportal endoscopic lumbar spine surgery in Indonesia. Maybe Kyiv, Ukraine, and also other city in Indonesia. For a young surgeon, young spine surgeon, we like to try this endoscopy, not only the technique, but we also prepare for the cost for the instrument. How much does it cost? Should I buy uniportal? Should I buy UBE, or should I buy another transforaminal endoscopic? I will give you the illustration of the price and also the journal. So what determines spine surgery, orthopedic, and neurosurgery to pursue endoscopic surgery? After we finish our medical students, medical doctor, we can continue the orthopedic or neurosurgery. And after 5 years of training, we can go for fellowship endoscopic, fellowship spine. And after that, we can enter the endoscopic fellowship. I myself, I entered fellowship endoscopic in India, Mumbai, under Dr. Satish Chandra Kure and also Dr. Malcolm Pestonji for six months. And I follow Dr. Kang Tek Lim also. From the evidence, we can find a PubMed, we can find 4,266 results of endoscopy. So after this presentation, maybe it will initiate your willing to learn about more about journal in endoscopic. You can find in PubMed. It is a free journal, and you can see the trend in 2021. The writings of the journal is getting high, so you can read every day this journal. So the evidence is not the barrier. So how about the technique? So if about the technique, you can search also the clear technique and how to start, how to insert the C-arm, how to insert the needle, how to put the scope, how to take down with the Garrison or anything. You can read in the journal, approximately 1,205 journal also. You can see it freely. So most current publication emphasize on indication, method, and complication, and so are seminars and webinars nowadays. So how about the patient? The media has also covered the news. They all talk about that minimal invasive can relieve the pain, can relieve your back pain with a minimal destruction or minimal hospitalization. Many patients ask the surgeon about the MISS procedure also to all the doctors. So it is the trend that mostly surgeons should try to do or should learn to do, because if you're not doing it, more patients will run to other hospital or other doctors who already master this technique. So it is you can try it. So what determines spine surgery, orthopedic and neurosurgery to pursue endoscopic surgery? The answer is the cost. I tried to find the PubMed. There's only 97 journal that talk about the cost effectiveness and price of doing endoscopy. And from this journal from Hong Kong, I tried to find the cost analysis comparison between conventional microsurgical decompression and full endoscopic interlaminar decompression for lumbar stenosis surgery from Dr. Prudence Wing Hang Chung. He said that in the Hong Kong dollar, it's for interlaminar decompression, it costs about 54,863. It's about $54,000, and USD is 7,055. Compared to the conventional micro decompression, it is 2,000 less dollar. So general ward, hospitalization, radiology, routine follow-up visit, unit cost of surgery, and also complication. So how about at the other country, in Korea, the cost effectiveness of microdiscectomy versus endoscopic discectomy for lumbar disc herniation? As we can see now, the cheapest, no, the lowest price is transforaminal endoscopic lumbar discectomy, like Dr. Koichi Sario presentation, that it need only local anesthesia. So the cost is the lowest here, at approximately only less than $3,000 and 24,870 for quality adjusted life year. And you can see this interlaminar endoscopic cost 3,600. UBE cost almost same with interlaminar. The difference is just the disposable use, because using of the probe, the counter probe, a plasma probe or something, and also the micro discectomy, the cost is higher because the patient need to hospitalize more time, approximately 3 days. For the endoscopic, it can be done in a 1-day hospitalization. So the cost is less in interlaminar. So how about the cost utility analysis percutaneous endoscopic lumbar discectomy for L5S1 transforaminal versus interlaminar? Here said in other journal in Shanghai, China, it is stated that transforaminal is more economics rather than interlaminar, because we can see that transforaminal can be done in the local anesthesia. So this cost is collected from hospital. Sorry. This cost is calculated from hospitalization expenses, laboratory, radiograph expenses, surgical expense, drug cost, physician cost, surgical equipment and material cost, anesthesia expense, and other treatment. And so their focus were a cost effectiveness, cost utility, but how much exactly the operation cost for full endoscopic lumbar spine surgery. So in Japan, I tried to find the journal. This is a very good journal presented by Dr. Hiroaki Manabe. It is counting the procedure and approaches versus fees, initial facility investment cost, and also cost of equipment and maintenance. It is a new journal, 2019, and it is said that 295 cases of full endoscopic surgery via transforaminal approaches, discectomy, foraminoplasty, and ventral facetotomy with the code insurance is K143-2. Reimbursement is about 303,900 yen, is almost same with less than $3,000, 2,780. You can see that for equipment cost required for 295 cases, this is the unit price, purchasing quantity, and its total. You can see here the endoscope 7 and the grasping for tab 58. When you start career in endoscopic surgery, it is different with open surgery because of the small incision, minimal invasive. It is used the delicate and gentle instrument. Like me, I started and I break some of grasper and some of endoscope. So sorry, this jump. So you have to think about the instrument. Once you break the scope, you cannot do a surgery. This surgery reimbursement is like this, but you can see the operating cost They count also the endoscope times 7, grasping forceps times 80, 58, drill bar and bipolar, and the result, the final result is 100,058, 590, 69 yen per case, or approximately 1,434 US dollar. And the hospital profit margin is 300,000 yen minus 100,058, and still profitable per patient, approximately 1,300. Seems profitable, but you have to remember the investment cost for basic endoscopic system, external cylinder, assisted device, bipolar forceps, main body system, high-speed drill, main body system, it costs more. So it will create problem for you as a young surgeon, young spine surgeon who try to pursue a career in endoscopic surgery. So I will give you an explanation or about Ford versus Ferrari. It is a new film, 2019. I will compare that Ferrari is is the one of the fancy car, and versus Ford is a general car in US. So Ferrari is a uniportal system, and biportal is Ford. They try to give the doctor that our technique is best, our technique is best, our technique give less damage, our technique give advantages. But you have to know that uniportal should use specialized scope. It means that the scope, the instrument should enter the scope, so you should create specialized instrument. But in biportal, you can use arthroscope system used by knee surgeon, or if you orthopedic surgeon, you can use your own arthroscope with a regular spine instrument. What you need to invest is a plasma counter or RF counter. I will give you an example for my setting. I use uniportal set A. I will give this A. Actually, this is the price of Karl Storz Gore system. Since I am the pupil of Dr. Satish Chandra Gore, I bought the instrument. It is cost 67,623, and Ukraine money, it is one. You can read this 1,880,393. You have to consider it. I use this for my case, my patient, and I broke one scope and also one grasper. So I still have no advantage in case of money, because I have to pay for the scope. And this is the second instrument, uniportal. This is supply system, PLD, PSLD, radio operator, and power drive. It is uniportal set B. It is the Richard Wolf instrument. It is cost about $398,033. In Ukraine, you can read it. It's about 11 million Ukraine UAH. Okay. So what about UBE? Based on the price I was offered by bonds, approximately full set only 44,450. So if you are trying to pursue career in endoscopic spine, this is a good start. You can start with this UBE. I won't promote this product because this presentation is sponsored by bonds, not, but it is clear comparison in the analysis of the cost. So if you see the buying seems to be expensive, how about renting the endoscopic set? I also make an illustration. If you are going to try the endoscopic first, you don't want, or your hospital do not want to invest, you can try to rent to the company at approximately 1,800. So you can see it is less economic. You can try, if you can do very good, you can try to buy start the UBE system. What about my experience? I did this in my hospital. I did also interlaminar and this transforaminal and this interlaminar. I did on Uniportal. And this is my hospital, academic hospital, Universitas Gadjah Mada. It is state-owned hospital under the jurisdiction of the Ministry of Education and Culture. It is rare because most of our hospital in Indonesia, it is under Ministry of Health. So this is because of teaching hospital, we are under Ministry of Education. So the cost become very problem in our hospital if we do surgery and the result is minus. This is a national reimbursement of insurance system. As you can see, this BPJS, Badan Penyelenggara Jaminan Sosial, it is in our country. For the economy class patient, the claim is only $500, and the class 2 business class only $650, and class 1 VIP is $753. I heard also this kind of reimbursement in Japan become problem to the spine surgeon. Some diagnosis means same tariff, no matter the treatment modality chosen. So if the diagnosis of the patient is lumbar stenosis and the doctor decide to do a open or endoscopic, the reimbursement of the government is still same. So it will become your matter in starting endoscopic career. My experience in Uniportal, I try to count my 30 cases covered by BPJS Kesehatan. In 30 case, the cost of use hospital is still minus per case. So if you want to try, you can calculate the price of your technique. And the majority expenses come from renting equipment, and also the problem still lies in the initial investment. That is my problem in doing endoscopic spine. But in my hospital, I bought my instrument and then I put in the hospital, and I don't ask for charge, or I charge for free, because if I charge for some money, it will be banned and the hospital cannot pay because the reimbursement is so low. So I use only for my private clinic patient. So how about the disposable if you do UBE? This is spine of leg offered by Bones Company. I will give you the cost is about 60% discount. This is the probe. It is cost about $558. And if you can see hospital stay cost in my hospital, we are trying to make an estimation between traditional open surgery and UBE, and we assume same operation tariff for both traditional open surgery and UBE. We exclude the price of drug use and other additional procedure needed since it varies per cases. When I did traditional open surgery with required hospital stay for 3 days and do not use ablator, the cost is approximately $156. If I did UBE, required hospital stay 1 day in VVIP, I use spine oblique ablator by this company. It costs almost $600. Still differ greatly. So what we can do, we can reduce the total cost in one case of UBE by reducing the price of ablator equal or less to 2 days hospital stay. We can reuse the ablator for some cases to reduce its price. I know it is illegal, but some of surgeons that did it to cut the cost of the surgery. But I do not recommend. If we cut this procedure, we can reuse 4 or 6 times to make the traditional open surgery same with UBE, but I will not recommend it. But if you want to try, it is on your own risk. This is a good for the last my last presentation. I will state to you that there is a good article from Dr. Pang Hung Wu. He is here also. Thank you so much, Doctor. Another factor, not only the anesthetic support, surgical expertise, and the technique, but the vision, maintenance, endoscopic equipment, and cost equipment also become problem.
Tiba-tiba mati.
Okay. Please silent your phone. And factor to consider in setting up sustainable endoscopic spine surgery practice, we are talking here about surgical expertise and continuing medical education. But do not forget, you have to think about also the cost of equipment. So the underlying problems seem to be present everywhere. What should we do? We should do more cases in UBE or Uniportal, so we can give advocation to the government that this technique is the new technique that can help the patient and is the new technique that can reduce the hospitalization. And after we did so many cases, the health insurance will see and will cover that endoscopic system may need more cost or more money, so they will claim or they give insurance in higher more money. And then for the conclusion, MISS surgery has been associated with advantages compared to traditional open surgery and has been known by surgeon and patient alike. But in Indonesia, endoscopic spine still only available for out-of-pocket case, not the one using government mandatory insurance. The main factor driving endoscopic procedure cost upward is the initial investment needed. And endoscopic companies should not only focus on the surgeons, but also give attention to each country's insurance regulation. This will make endoscopy surgery available for wider patients. As the number of patients grows, so will the yearly income. As the business grows, so will the production of the devices increasingly automized. This will reduce the cost protection for premium spine endoscopy product, making it available in lower price. So it's not about the money only, but to help others in need. A business that makes nothing but money is a poor business. It is stated by Henry Ford. Thank you very much for your kind attention.
Thank you very much, Dr. Mangione. Thank you for transfer all the expenses to any currency. Thank you very much for counting this. And now, with a great honor, I would like to introduce my first teacher on UBE, Dr. Hayati. Welcome, Dr. Hayati. Your presentation.
First of all, I would like to thank to organizing committee, especially Dr. Fishchenko, for their kind invitation of this valuable and privilege. There are many privileged speakers. I'm very happy, and it's my honor to speak in this webinar. My presentation, and also I want to add the talk about Dr. Song. He's changed firstly in my life, and I think many endoscopic spine surgeons, they changed their life because of Dr. Song's very valuable efforts about the development of the unilateral biportal endoscopic technique and concept. So I would like to talk about the short review of endoscopic developments and the considerations and some endoscopic solutions for some current and difficult problems. My presentation plan will be consist of these topics, especially in the first 3 topics. I will pass very fastly. Just want to memorize about the endoscopic developments. So you know, there are many common or conventional spine surgical techniques. This development is continuously going on from the open surgery to microsurgery, and then, you know, the MSI techniques developed very fastly in a short time, in recent years. But still, we need some another different techniques because of some constants and difficult problems. Some of these problems were coming from the conventional surgical techniques. And then these developments jumped to the endoscopy. And today we have many endoscopic techniques. And if we have to define roughly the endoscopic techniques, the means of endoscopic techniques is the spine surgical intervention under the inside visualization. So means that during the endoscopic surgery, our eyes in the canal, and this visualization can be percutaneous or tubular. So I told before, open surgery is still performing in many surgeons. Also, I am using the open surgical techniques. But we know that there is some constant problems. For example, there is no way to prevent the muscle fibrosis, muscle formation, which is causes for the chronic back pain or chronic cervical pain after the surgery. There's some also the epidural perineal fibrosis and the facet joint damage and can cause the chronic pain. It can be behavior as a pain generator. So to minimize of manipulation is not so easy with the open surgeries. But in endoscopy, we can protect the muscle and we can protect the joint and joint capsule. And also to protect of the posterior lamina and the ligamentous complex is possible. And the epidural or perineal fibrosis is low than the open surgery, we know. And the most important thing is minimizing of the manipulation is like possible with this technique. In the literature, there are many papers about the muscle fibrosis, muscle complex after open or conventional microsurgery. And also they made some classification about the muscle fibrosis, muscle formation after open surgeries. So if we look at about the clinical result of endoscopy, we can say that all the results after the surgery, all the term of results after surgery, endoscopic surgery can comparable to microsurgical results. And also we know that the better results, or the results is better, especially in early period of after surgery. And you know, decreasing the time of stay in hospital and return to work is very big advantage of the endoscopy, which is, we know that it's my practice, my patient after surgery, just one night or daily surgery can be done after the endoscopic surgery. And also revision after endoscopy is very easy because of limited approach. So the endoscopic surgery have a target, of course. This target is to increase the benefit zone. It means that the technique should be available for the maximum benefit with the less traumatic surgery, with the applicable in, it should be applicable in all spine regions, and this technique should be available for the stenosis that accompanied by deformity, and it should be available for the segmental fusion, and it should be available for the enough decompression in even multi-located stenosis, and it should be available for the applicable in revisions, and especially in elderly and the comorbid cases. In the recently, you know, there are many endoscopic techniques, developed many endoscopic approaches. So there is a conflict about this. And we need actually clear and acceptable for all the endoscopic surgeons and clear classification system. It can be classified according to the portals as uniportal, biportal. Also, it's possible to classify it according to the medium, for example, air or dry medium or fluid medium. But you know, in AOSPINE, in the consensus paper is a very important step for the classification of endoscopic surgery. This name is consensus paper. Okay, there is a consensus about the monoportal or uniportal endoscopic spine surgeons about this classification system, but I think that it needs a revision after Ube developments. For example, they saying that the full endoscopic surgery means should be clear and acceptable. But this the AOSPINE consensus paper is very important step to speak a common language about the endoscopy. So let's look at the endoscopic procedures. You see there is many endoscopic procedures and approaches for almost all type of spine problems. But these innovations and developments are still going on about the endoscopic surgery, especially in monoportal, fluid medium and biportal techniques. For example, in cervical, I wrote the red words about the newest and all the recent developments, or the target of the endoscopic in recent future, in the near future. So in cervical, you know, the posterior discectomy and also the posterior stenosis surgery still going on, still be done with different endoscopic techniques, but anterior endoscopic technique is still under development. In the monoportal endoscopic technique or full endoscopic technique can be done by some very skillful endoscopic surgeons. And for example, the tumor debulking in the cervical and the thoracic and the lumbar area can be done with UBE, for example. And also in the lumbar area, the decompression by foraminal way is almost impossible for now, but maybe in some special device will be possible. Also, intradural extramedullary tumors maybe in the near future will be dealt with endoscopic techniques. And also compared for foraminal decompression, it's possible for now. And also inside or intracanal foraminal decompression can be done. But all these developments, although all these developments, still we have some constant and difficult problems. I tried to classify these problems as disc and decompression after decompression surgeries and the instabilities. I will show you some examples for this. Yes, so the question is it possible to prevent the fibrosis formation after endoscopic surgery? It's the answer is not so easy. The fibrosis development is almost unavoidable if the dura peripheral tissue interface is violated. So what should be done for this? We can keep intact the interval of the flavum and the dura. It's very interesting and important for me. We have a project and about this still going on, and I'm talking about this project. If you don't keep the intact the interface between the dura and the phleum, you cannot prevent the fibrosis development. And also, we should make our manipulation very limited, and we should reduce the necrotic effect process. For example, we should use less radiofrequency and less electrocautery, and we should minimize the retraction of the neural tissues, and we should prevent the hematoma. It's very important. Also, we can use some anti-adhesion barriers and anti-adhesive materials, and maybe you can repair the ligament of phleum, but we did in many cases, but I will show you what happened. So, if we should have a non or less manipulative surgery and annular dilation instead of annulotomy is very important, and using the biorepair materials or repair enhancer is another important point. Well, and using anti-adhesion barriers may be promising for the future. But it is our dreams, of course. The phleum sparing approach is good, and the phleum repairing maybe it can be a solution, or annulus repairing is a pink imaging for us, but the reality is not like this. In uniportal endoscopy, actually, there are many speakers told about this, and I want to show you a biportal endoscopic solution for these problems. We know that, and also previously, the many valuable speakers told about the differences of the UBE from the other endoscopic techniques. So I just want to summarize this, that we have in UBE have very beneficial field of view. The field of view, very important point for the endoscopic surgeries, but maybe we can talk about the two types field of view. The one types of, you can see something, some target inside the canal, but your technique is not led to access of this technique, of this target. But in UBE, the beneficial field of view and working distance is superior than all the other endoscopic techniques. Also, the surgical field is more clear than the other techniques. And another important point is, indirect approach is less in UBE. It means that in the monoportal or in the fully endoscopic techniques, for example, the upper migrated disc, sometimes we can manipulate to remove the disc without visualization, but we just feel that yes, this fragment should be located in this point, and we can remove this without we can remove this part blindly, not clearly seen. In UBE, this the indirect approach is very less, but direct approach is more. So we can use the assistant hand as an additional hand. So we can say that the UBE is B-handed surgery. And also posterior and the posterolateral approach is more effective than the monoportal or fully endoscopic techniques. And but the disadvantage is still transforaminal approach is not possible. So in disc surgery, we have some special approach. For example, the flavum sparing technique instead of flavectomy we can use. It is very easy in uniportal technique. The flavum repairing is easy in biportal, but non-manipulative approach is important for more of uniportal and biportal technique. And we should change our approach to make a target direction. For it means that we should use the target-oriented approach for fragments. And also annular dilation can be an advantage for us. So in this video, you see the fragmentectomy. We are trying to make the clear of between the flavum and the bony interval or border. And I'm removing just ligamentum flavum superior layer, not touch to the in deep layer. And we should choose our maybe we can manipulate our approach or portal placement accordingly with the fragment. So just I'm sparing the ligamentum flavum without removal from the bony border. And the very important thing is we never touch to the dura flavum interval. Is very important for me. If you don't need to touch, you never touch to the even vascular structure. Now you see here the fragment here. We don't need to touch to the other innocent tissues, or we don't need to make a retraction of the neural tissues excessively. Just enough, very small. The aim of this surgery is to make a smallest footprint of the surgical field. So you see here, and I will show you after the revision after this flavum preserving technique, and you will see what will happen. Now, after all this, we need just less than 1 centimeter, less than 1 centimeter defect is enough for us. We don't need to make aggressive surgery, and we should be aware of the flavum dura interval. Is very important structures placing in this interval. Yes, it's enough. No need to touch another structures. Is enough. Okay. Check the position after removing the disc part. Enough. We finished. Now it's finished. You see, this is the 2 millimeter wide dissector, and here you see this is our defect, and this is, you see here, the interval, and this is preoperative and the postoperative immediate MRIs. You please be aware of the muscle edema. So there is some solution may be promising for the preventing of the fibrosis formation development. We can use endoscopic annulus repair with some textile implant, and we can use some nucleus pulposus implants, and it's possible to use the bio-repairing enhancer. And also in the future, maybe we will use the gene therapy and the cell treatment. That some studies we can find in the literature. So how can reduce the reherniation? We can say that it's not so easy, even endoscopic surgeries. We can reduce maybe instead of discectomy, fragment removal instead of discectomy. Maybe we can try to protection of the annulus, and we should we can use some accelerating recovery agents, or the most important point is the case selection to prevent of the reherniation, and the postoperative limitation of the patient, also other important point, and the patient education is very important. But we can say that, especially in young men, reherniation almost cannot prevent. So we should be aware of this. If we're doing endoscopic disc surgery, we should think that maybe in the near future we will face with this case with reherniation. This is my case. After 1 year discectomy, Ube discectomy, then we need the reherniation surgery. We did for this case before in the first surgery, ligamentum flavum preserving surgery. Let's see what will happen in this video. Now you will see the flavum completely intact. Even we cannot see the that we created the bony flavum interval before the surgery. You see the reattachment of the ligamentum flavum to the bone. Now you see almost the ligamentum flavum is intact, but still we're seeing the fibrosis formation between the dura and the flavum, not flavum to surround tissues. Dura, flavum. You see, very severe adhesion still exists. So we should be aware of the dura-flavum interval. It's very important. Even if you can repair after surgery, the repairing of the flavum is maybe is not a solution. Maybe you can use for make a barrier between the surround tissue to dura. Okay, but to prevent of the fibrosis, you should keep intact to the dura flavum interval. Otherwise, impossible to prevent of the fibrosis development. Now you see here, the flavum is completely intact, but we'll see the severe adhesion formations. We should look for a good solution for the prevent of fibrosis development. Now I will show you another. Yes, this is after this previous case was after endoscopic surgery. So what happened if we revise the after open microsurgery. Let's see what happened. This is after open surgery, endoscopic revision after open surgery. You will see very massive muscle fibrosis. We are inside the muscle fibrosis now. We cannot see any natural tissues. You see, this is after a microsurgical surgery. You see, there is very severe fibrosis. Yes, you see here. We are trying to. I just want to found a friendly tissue to see the. We should found firstly in a natural tissue or version tissue. Then you can widen your approach to see the disc. Now you see we cannot see the dura, we cannot see surround tissues. Also, they removed the flavum after microsurgery. Now it's very dangerous about the dural tear or neurological compromise after surgery. See here, yes, this is the disc. So we can say that the revision after endoscopy is has very advantage, has good. Then I always prefer to make revision after endoscopy, not after microsurgery. And this is after revision, immediate MRIs. So let's see the stenosis surgery. Still, we have many approaches currently, and also there are many techniques using. Also, we have using sometimes very successfully, and also we have many endoscopic approaches. So our results with the endoscopy, at least comparable with the open surgery, at least. But mostly, I can say that especially in the early period, results is superior than the conventional surgeries. But in the literature, there are many different some suspectful results. And we can say that the tubular endoscopy equal results, microsurgery and posterior monoportal, and the tubular and the microsurgery almost same result. And the foraminoplasty is in some special or selected cases has very good results. But we can say that the Ube decompression results are higher in every period, but the technique is new yet. So many factors affecting the results, we know that. And these factors can be dealt with or can be answered by Ube. What is these factors? If you want to get acceptable results from the stenosis surgery, you should be aware of all this. For example, the stenosis surgery, a kind of lateral recess surgery. Okay, if you have very enough lateral recess decompression, you will have a good result. Otherwise, the central decompression is good, but is still not yet good or not enough results can have. So the subarticular decompression, foraminal entries should be decompressed, and we should preserve the stabilizers, and we should prevent the muscle fibrosis, muscle formation. It's possible to make muscle fibrosis, muscle formation even in endoscopic surgery. So endoscopic surgery should be applied as real minimally invasive surgery. And also we should deal with all the segments, the stenosis, to get a good result. So we have many type of surgeries for endoscopic stenosis surgery. If you talk about the posterior monoportal endoscopy, and many uniportal or full endoscopic surgeons developed very good techniques, and the UBE also, I believe that UBE have good advantage. For example, we can use this technique for the central stenosis decompression, lateral recess decompression, especially total decompression, means central recess and the foraminal decompression. It means that you can decompress the both of upper foramens and the cranial and the caudal foramens, and also intercanal foraminoplasty can be done. So you see briefly the advantage of the UBE decompression that many of speakers told about this, and I passed in this literature. You see the UBE has very big advantage for the stenosis surgery, in the stenosis surgery. So also many speakers present very well about the sequences of decompression of UBE decompression. Just want to show you a sample to use my time. This is the case, preoperative MRIs, and this is the surgery. Yes, I'm using, like many surgeons, the very strong tools. For example, big punches and the osteotomes, and the big drills also. And here is the lower lamina. Just I'm starting to do flavectomy from the cranial side, not caudal side. I think that it's maybe for me it's more safe to start the flavectomy from cranial side, but of course I saw many surgeons starting the flavectomy from the caudal side. Of course they can, but now you see the contralateral side, upper contralateral side, upper foramen decompression. I will show you. Maybe we can make a little bit. I want to show you the results. I'm using, this is the intracanal foraminoplasty. You see, this is the upper foramen of the contralateral side, and here is the lower foramen or caudal foramen of the contralateral side. You see, completely we did foraminotomy. So what about the ipsilateral side? Yes, I'm using for this 30-degree endoscope to make ipsilateral or same side decompression. with the unilateral approach. Now, here is the ipsilateral upper foramen. This is the nerve root. See here, this is the nerve root, and here is the axilla. Now, and here, the disc level. This is the upper cranial side or exiting roots, right side and the left side exiting roots. Now, here is the traversing root. You see, traversing root, ipsilateral traversing root. This is the contralateral side traversing root. Here is the pedicle, contralateral side pedicle here. You see, and here is the right side exiting root. This is the, now you will see the left side exiting root here. You see clearly, left side exiting root here. Then you will see the traversing root of the left side. You see here, this is the axilla. So we did a unilateral, 2-portal, and 4 foraminal decompression with some special tools with and the 30-degree endoscope. Now I will pass very fastly the endoscopic fusion fixation. You see here, according to the literature, the biportal technique have big advantage if you compare the other techniques. And this is a kind of sample. This is after 3 times microsurgery. The case was almost paraplegic. And this is the surgery. I'm sorry for this video is not clear, but I want to show you the disc removal. Now, sorry. Yes, I want to show you the disc removal. Here, we remove the very big disc. Then put the cage, and then we did fixation. I pass because many speakers show us very nice cases. So we have also some complications. Also, my colleagues mentioned about this complication in their presentations. So I want to pass. There's also the endoscopic surgery has some disadvantage for uniportal techniques, has some disadvantage. For example, the bleeding control is difficult than biportal, and the manipulation of the neurological structure is not so easy, and the field of view is limited, or beneficial view is less than biportal. Also in stenosis, to access to all of the targets is not so easy with the full endoscopic surgeries. Of course, some experienced surgeon can be done. Also, they doing very perfect decompression, but we are talking about the general surgeries. So, and it can be takes longer time than UBE, the monoportal techniques, and using the big or strong instrument is not possible with the monoportal techniques. but the foraminal access to spinal canal is impossible with the biportal techniques, and the foraminal and ipsilateral disc management is difficult with the biportal techniques. And in the posterior approach for disc and fleum is more affected than the uniportal endoscopic techniques. We should be aware of this, and we should protect the fleum dura interval. And also the management of the ipsilateral upper foramen is not so easy. Thank you for your patience.
Thank you very much. Thank you very much, Dr. Hayati. And the next presentation, I want to introduce Dr. Tian Dasheng from China.
Okay. Good evening, everyone. My name is Tian Dasheng from the Second Hospital of Anhui Medical University in China. The topic I report today is Ube for lumbar spinal stenosis. No, sorry. Ube is a novel minimally invasive spinal technology derived from a unilateral biportal endoscopy. The U means unilateral approach, the B means biportal, which is both wheel and work portal. The mean demand it is an endoscopic surgery. About the technical means of Ube, we can think about the two percutaneous separation channels were used to create a working space inside and outside the spinal canal. So to complete the decompression and the utilization of nerve tissue. And talk about the technical characteristics of Ube. The point is the wheel and the worker portals are separated, which could bring us two benefits. First, it could give us a clear and open endoscopic vision. The second, it can provide a flexible and convenient operation, large operation space, wide movement region. Now I will introduce the operation process of Ube, Ulbd. A key point of operation process in lumbar spinal stenosis is a bilateral decompression, which could be also called Ulbd. So how to complete Ulbd decompression through Ube technology is the core of my topic today. The following 3D scan shows the decompression in spinal canal before and after the Ulbd surgery. And first of all, the operation position of the patient is very important. Compared to prone position, this is a low head and low foot position with the surgical area as the apex. We call it the jackknife position. And the operation position could facilitate the operation and enlarge the laminar space. After putting the operation position, we should use the CM to location the target laminar space. Adjust the position to make the projection of the vertebral body straight line. It is easy drawing the target. The next target is the location incision on body surface. The low edge of the upper pedicle and the upper edge of the low pedicle were marked with lines, which is the horizontal line in the imaging, and marked a line along the inner edge of the pedicle, which is the vertical line in the imaging. The junction points are the entrance of wheel and work parties on board of the surface. What we need to do next is establish the channel and expand the soft tissue. The key points of the soft tissue expansion is first for wheel channel, we need a 2-stage expansion, and for work channel, use 4 or 5-stage expander is necessary. And last, proper dissection of the soft tissue on the laminar surface. At the beginning of the operation, our most important work is recognize the bony structures, which means identification of the upper and the low edge of lamina. Our experience in this step is use the bone touch. First, use the stripper touches the bony structure along the laminar edge, and roughly determine the location of the touched interlaminar bony structure. Sorry. Don't. Why? How to recognize the bony structures, we could establish the primary working space. The key points in the step as follows. The suitable water pressure, which means smooth water flow. Intraoperative blood pressure to reduce bleeding, and appropriate muscle relaxant is also very important for the smooth operation. The next slide will be displayed the endoscopic structures. In this picture, we can see the exposure process for low edge of the upper lamina. The area is also shown in the left picture. In this picture, we can see the exposure process for inner edge of the articular process. The bone have not been removed yet. In this and the following picture show the bone removal process for inner edge of the articular process. That is the area indicated by the arrow left picture. This picture shows the laminar space and the ligamentum flavum. And the exposure process for upper edge of the low lamina. The sign of the completion of primary workspace, actual vertebral canal, is the low edge of the upper lamina, the inner edge of the articular process, the ligamentum flavum, and the upper edge of the low lamina. For successfully exposure from the inside to the outside. The structure are shown in the sequence above. After the establishment of primary worker space, our next goal is zone decompression for low lumbar spinal canal. We divide the decompression area in 3 parts. First, the ipsilateral spinal decompression area. The second, the middle line decompression zone. Third, the contralateral spinal decompression area. Different decompression sequence planning and approach strategy could be used in this step. We can decompress from middle line to ipsilateral to contralateral. Also, decompression can decompress from middle line to contralateral to ipsilateral, which is the most common way. This picture shows the ipsilateral spinal decompression area on the left side of the color marked area in left picture. The red area is the attachment of the ligament thermoflavum at the low edge of the upper lamina. The key point is one decompression head to the attachment area of the ligament thermoflavum. 2. Decompression afterwards to 3 laminectomy puncture or wadis. The picture shows the process. Use a high-speed bone and use the laminectomy puncture. So many junior surgeons confused how to determine decompression distance and the endoscopy. About Ube endoscopy measurement tool, our Ipsilateral is use high-speed bone or laminectomy puncture as a reference. The drill bit of high-speed bone is about 4 millimeter. Back to the picture. The black area shows the medial body of the inferior articular process. The main point of this step is when you use the 30-degree endoscopy, it can be rotated to adjust vision. Avoid the excessive excision and the elbow laminectomy puncture could be used. And last, decompression to the termination of the ligamentum flavum. Let's see the short video of the medial body of the inferior articular process. We can see. In order to save the time, I'll just jump. The following picture shows the forming process of the medial body of the inferior articular process. Let's come back to the picture again. The green area shows the ligamentum flavum attached area of inferior lamina. In this step, the decompression point is 1. Appropriate grind of bone. 2. Pre-hemostasis and reverse laminectomy puncture could be used. Please check this video. The ligamentum flavum attachment area being revealed. And this picture shows the low margin of the ligamentum flavum. The same picture, the purple area marked the laminar transition zone of the superior articular process, which also be called the corner area. In this area, decompression points is 1. It's a relatively vulnerable area. 2. Elbow laminectomy puncture could be used but no need to slender bone. 3 is the entry point of layer resection of ligamentum flavum. Please check the video. Define the layer of the flavum. This picture shows the decompression of corner area. About the simple advancement of the section of ipsilateral ligamentum flavum. First, certify the resection of reduced bloody Second, always remember protect the nerve structure. And last, pre-hemostasis to keep your vision clear. The video shows resection of ipsilateral ligamentum flavum. And so are the picture. Ipsilateral resection decompression and nerve root exploration is very important for the final result of the operation. Ensure nerve relaxation without compression and adhesion. The video shows the exploration of ipsilateral nerve root. Similar to this picture. The second part of the Ulbd decompression row is the middle line row, marked in the picture. When cross the center line, they represent the beginning of overtop decompression. Correct identification of middle line, and they are also significant. How to determine the middle line structures? The fluoroscopy methods could be used. Following pictures shows ipsilateral decompression cross the middle line and contralateral decompression status and CM fluoroscopy during the operation. Back to the endoscopic vision. Ligamentum flavum middle line got A mark. We call it the V neck. You can see V neck. The next step is bone processing at the basilar part of spinal process. The osteotoma and laminectomy puncture could be used in bone processing at the basilar part. The speeder bone could also be used. Next step is the purging of contralateral spinal canal structure. Protecting dural sac is very important. The purging of the medial wall of contralateral pedicle is important to release the contralateral nerve root. We can see the nerve. This is the pedicle. Finally, release the contralateral nerve root. Check all procedure and the instrument. Close the incision. And last, let's review a case of lumbar spinal stenosis treated with Ube, Ulbd. It's a 49 years old female. Come to hospital for intermittent claudication for 1 year, aggravating 3 months. This is a pre-operating DR image. And this was the pre-operation MRI image. That show L4, L5 lumbar spinal canal show obvious stenosis. The CT scan. I can show the laminar space is very small. The diameter of spinal canal decreased significantly. After Ulbd surgery, as mentioned before, the double incision shows that the wound on the body surface is very small. Let's check the post-operative imaging, MRI imaging. The decompression of spinal canal is very sufficient. sufficient. The post-operator CT imaging shows the range of bony decompression. The data sign on behalf of the Ulbd technology. The region of bone decompression is limited, which is the little effect on spinal stability. Sorry. This is the decompression of the post-operation, the decompression that show the laminar space. In the end of the topic, for all spine minimally invasive surgeons, we should master various technology of the operation and actively and safely carry out minimally invasive spinal endoscopic surgery. And the Ube technology is an optionally minimally invasive spinal endoscopic technique. Thank you for your attention. Thanks. That's our report.
Thank you, Dr. Taiganda Sheng. Thank you very much. And now let me introduce the next speaker, Dr. Javier Julio Olvera from Mexico. You're welcome.
Thank you very much. Let me share my screen. Can you see my screen right now?
Yes, we can see.
Perfect. Thank you very much for your kind invitation, Professor Fishenko. It's an honor to stay with you, all of guys, talking about endoscopy. I'm going to talk about some of a Mexican experience using the biportal endoscopy in lumbar spinal stenosis, the current applications of UBE in this degenerative pathology of the spine. Well, as you know, and other faculties have commented before, unilateral biportal endoscopy is a truly fully endoscopic technique where the surgeon works with familiarity through independent two works. Basic concepts regarding the approach is a triangular approach formed by two vectors. The vectors needs to join in the target to address very highly precise the pathology, the inflow of saline solution goes through the endoscope and creates a space. The hydrostatic pressure increase the space to work below the muscles in an epiperiosteal space filled with connective tissue and fat tissue. And in the most traditional way, you can work in the pyramid through a pyramidal approach medial to the multifidus muscles in a triangle, very well established. But what about the background? What about the evidence that made us to take decisions regarding the patient? Well, this is a very good paper published by Korean author Sang-min Park. He addressed how can reach the decompression in lumbar spinal stenosis in 32 patients comparing with microscopy decompression. But the pairs that need to highlight it in this paper are that they use a very strict indications to perform this study, this randomized control trial. They included patients with degenerative lumbar spinal stenosis with low-grade spondy, no instability, with no lumbar discernation, no scoliosis or other disorders, only degenerative spinal stenosis in a monosegmental levels in 32 patients, comparing with 32 patients underwent microscopy. And the outcomes were encouraging regarding biportal technique. The final outcome, no inferiority of biportal technique compared with microscopy. And this technique is quite convenient because the manipulation of spine instruments is easier. every and each surgeon knows that we need the two hands in sometimes or with some patients, and biportal endoscopy offers that kind of advantage. And highly specific study, this is a very highly specific study as approved to perform this technique in patients. Well, and summarize the advantages regarding biportal. We know that we can obtain clear visibility of the neural structures, decreasing the risk to damage to the neural structures. We can reach very highly precise these targets in the canal, in the lumbar spinal canal. We can use with familiarity the common surgical tools made by different brands, and you can move in the surgical field free. The camera always follows your right hand where you are handling your instruments. The anatomy, it's very similar to microscopic. So relatively, a short learning curve is needed to perform this technique. So another question to perform biportal technique, unilateral biportal technique in degenerative pathology to decompress neural structure is if we obtain enough decompression through this technique. The answer is yes. There's several papers in the literature proving that unilateral biportal technique can decompress the bone structures and ligament structures in the spine to reach and decompress very well the neural structure. So comparing to other techniques, we can obtain very well decompression of the neural structures with several unilateral biportal techniques. And obviously, since 2016 and today, the increasing literature, scientific literature with more quality in the evidence is published in several journals. So we have proofs, we have evidence to perform these techniques in our patients. And what are the options to perform decompressions in lumbar spinal pathology, in degenerative spinal pathology, where we have compressive neural structures? Well, as other faculties also said, the Ulbd is very common technique, very well known common technique to perform decompression of the lumbar spinal canal. The indications, well, we can have mono or multi-level central stenosis. We can have degenerative spondylosis with broad-based lumbar disc herniations, with low-grade fixed spondylolisthesis patients, with mild to severe degenerative stenosis and scoliosis with patients with neurogenic claudication, unilateral or bilateral radicular symptoms. The most traditional and most known approach to perform Ulbd through unilateral UBE is the paramedian approach. As you know, the target to reach out is the junction of the spinolaminar junction, and then we can starting with the circumferential decompression, and then in an over-the-top fashion, we can reach the ligamentum flavum and the neural elements finally. The steps, as Professor Tian described it previously, we can, I'm just gonna resume, we can clean or surgical field of the connective and fat tissue overlying the lamina. Then we reach the ipsilateral lamina. Some patients has a very acute angle of the lamina. Then we cross the midline to perform the circumferential bone decompression. Always, my advice is care the ligamentum flavum, obviously to avoid damage of the neural elements with our surgical tools. And finally, we can detach the attachment, the cranial and caudal attachment and lateral attachments of the ligamentum flavum to obtain enough decompression in a patient. The flavectomy can be done piece by piece or in block, depending on our patients. Take care of the fibrosis or some adhesions between ligamentum flavum and dural elements. Finally, the contralateral side is approached to decompress the traversing nerve if this is the goal, but you can reach 4 nerves in one shot. If you perform a sublaminar approach, you can reach the contralateral superior part of the foraminal area, the medial foraminal area, and then decompress the exiting nerve also until to reach both nerves in one shot. But depending the goals of the surgery, depending the goals in your patients. Other techniques to decompress the lumbar spinal canal is in patients with asymmetrical stenosis. We have several information, several literature as a background. This technique can be applied in mono or multi-level asymmetric stenosis in patients with subarticular or intracanal foraminal stenosis, very specific stenosis. This technique can be used, for example, in juxtafacet cyst, and unilateral and traversing nerves can produce the symptoms, and these patients are suitable for this approach. This approach can be done by 2 ways, through a paramedian approach in removing the basilar aspect of the spinous process and pass to the other side or contralateral side, but you can take the advantage of interlaminar window and then perform a very specific contralateral interlaminar approach. And also you can reach the contralateral foramen through a sublaminar approach, removing the base of the spinous process and making a keyhole. This technique was published by Professor Park from Korea, South Korea. And this is an example respect the stabilized structures until reach the contralateral traversing nerve or the contralateral exiting nerve. Also, we have options to treat foraminal diseases, stenosis, through biportal technique. So this approach is made by a modified Wills lateral approach of paramedian, because this is a paraspinal approach, more lateral approach to the extraforaminal area. So we can reach this area and observe directly the SIP, the inferior articular process, the isthmus, and the transverse bones. So the approach starting recognized or observed the superior transverse process of the index level, and then when we remove or cleaning or fat tissue or connective tissue, we can reach the isthmus and the foraminal area or the extraforaminal area, and then circumferentially or craniocaudally removing the bone elements, we can reach the tip of the superior articular process. This approach also benefit to the patient because you can reach also the nerves that gives fillings to the facet joints. So a rhizotomy can be done through this same approach. But especially in patients with severe lateral recessive stenosis or foraminal stenosis are suitable for this approach. You can see in this case a patient with a severe degenerative foraminal and lateral recessive stenosis, and then we reach the decompression through this unilateral biportal approach to the foramen until reach our goal, that is the exiting nerve, or if the patient needs, the traversing nerve. So the other options to go ipsilaterally directly and highly addressed to pathologies that are compressing in the ventral epidural space the neural elements in patients is the decompression of the lateral recessive stenosis. So this approach is suitable for patients with unilateral radicular leg pain and lateral recessive stenosis. Mild or lower back pain is not a contraindication, but internal instrumentation demanding situations should be considered with other techniques, for example. So, for example, in this patient with a low-grade rostral migration, we can reach the target through this approach. The same goals and the same steps are made, but ipsilaterally. You reach the ipsilateral lamina, perform a small laminotomy until reach the attachment of ligamentum flavum, then complete the medial facetectomy and detach the ligamentum flavum laterally until make the partial flavectomy until reach the traversing nerve and follow the traversing nerve until the next level. But you reach the disc, you reach also the lateral recess area. So as a conclusion, we have several options to treat lumbar spinal stenosis right now through the unilateral biportal endoscopy. Not all is ULBDs for all the patients. So we can be very or highly specific for different kind of pathologies in different patients with lumbar degenerative disease in the spine. So the related advantages to this technique is all the associated with MIS, as we can see and we can read in different literature. The UBE technique is emerging as another option in full endoscopy surgery. For example, in Mexico, the costs are reduced comparing with Uniportal with different brands. Some doctors find very useful this technique because the technique is very similar to open surgery. The surgical field is very similar to the stereoscopic view of the microscope for some doctors, but we have advantages because we can reach spaces in the spine and we can observe directly our target area. So more scientific production is needed. Is obviously this technique is opened to all the world since Asia, so we need more production, for example, in North America, Canada, and some parts from Latin America. The technique maybe is not good viewed or seen because the doctors need to reach or learn more about these beautiful procedures and very specific procedures. Thank you very much for your kind attentions from Mexico, and thank you again for this kind invitation. It was an honor to share my talks about biportal technique with you. Thank you very much.
Thank you very much. And let me introduce next lector. It's Dr. Saifuddin Hussein from Indonesia.
Okay, I think that everybody can see my screen.
Yes.
My name is Saifuddin Hussein. I'm an orthopedic spine surgeon. Now I'm working in the hospital, working as a group with Dr. Armantia and Dr. Rizky Gatam. So I think they already presented beautifully about the UBE technique, but I want to present here my my journey about I'm doing only the PSLD. I mean that uniportal, not biportal. So I think there's a new, not new. I think it's UBE newer than this one. But let me present my journey. As we know that in traditional open surgery, that a lot of complication, a lot of disappointment about the result of the surgery, and especially the cosmetically is so troublesome and so scary for the patient, and as well as the infection level. And then along the way that we know that the open surgery, they have a lot of some complication like muscle retraction, some approach related complication according to the bone resection of the lamina and fascia joint, and some nerve retraction causing some scarring and 10% end up with the what we call the epidural scarring, and this is make me not happy. So the patient was not happy. So I changed my technique into the microscopic decompression. But again, I was not so happy, and the patient was not happy about the results. So I learned some technique. I went to some workshop. I learned from some, I think there are some prominent name like Choi, Young, and I stay for the microscopic, the endoscopic in Uriduls, and I went to India, and I I went to see some workshop, including UBE. I met Dr. Son, and then I was amazed about the technique, and then I start doing my case, and I learned from Kang Tek Lim. I think he's the quite big name in the PSLD. So this is my armamentarium. This is my weapon. I use a Korean, and then I use Max Moore and Richard Wolf endoscopic for stenosis, the S-gun. Then this is I do mainly for stenosis for the PSLD, and same as the other technique. I think I use some burr, and as you see here, just like the other technique, including UBE, PSLD, the main goal is to decompress. And then along the way, sometimes I found herniation that block and then cause compression of the stenosis of the lumbar canal. And then just like the UBE, what you want to achieve is you want to see the full decompressed nerve, as I can show you here. This is my case. I can see the axilla of the nerve. And again, here I want to show you this is my using one portal. This is, we can see here the dural, and this is the axilla of the nerve. Then I try to reach the other side, contralateral side, using the PSLD technique. And then I did this technique about 2 years, and 2 years I had about 100 cases, and then I still do the microscopic decompression because for some specific reason, and the age, the mean age is about 50 years. Then hospital day is about 1 or 2 days. Then I evaluate my work with a visual analog score, the post-operative 6 months, and the alteration of the fast, and then operating time, my failure rate, the blood loss, complication, and reherniation. This is my case because I consider myself as a still learning and beginners. My time roughly average about 2 hours. 2 hours case. I think it's not so easy for me to do this kind of case. And then you can see my time is about the same, 2 hours, not more than, and is about 2 hours. And then the operation time and the blood loss is I cannot measure because is using the washing with a lot of saline, and I have a 12 complication, mostly due tear, and some I need to do re-operation of the 6 cases. But my visual analog score, especially the walking distance and the claudication improved significantly. And as long as with the ODI, I try to measure the ODI is improved significantly for the stenosis cases. And for the satisfaction of the patient as well, I think that most of the patient happy with the PSLD. And this my complication, some persisting complaint and claudication still 6, so I need to change to the open surgery, and I have a dural tear, so I need to switch to open surgery. And most of the cases, 10 cases complicated is with the dysesthesia. I think it's because of the surgery is too long. And the question is how many cases should be performed this kind of endoscopic surgeries to master it. And then try to conclude that the learning curve is steeper than the traditional surgery, and you need to change the view, and you need to orientate the endoscopically. You need to switch because I learned from the open spine surgery to the endoscopic surgery. So I need to reorganize my thinking, my view to this kind of surgery. The question is for me is when is enough is enough to decompress, because a lot of criterion about using the how decompress from the pedicle to pedicle, or even using the size of the burr. But when you say enough is that's the end of the surgery. So in my thinking that see one, do one, and teach one does not apply here. You need to stick to the good mentor. And lastly, and the end of my my presentation, because I was elected as a chairman of Endoscopic Indonesian for the orthopedic, and the vice chairman of this Asian minimal invasive and endoscopic. Due to COVID-19, we're supposed to have this offline meeting, but now we changed to the online meeting. So anybody that who is interested, that I would like to invite everybody here to join our meeting, to share the knowledge and make a new network and connection. Please come and join. And we will conduct in the 2 days online, and then next year Indonesian will be the same host again, because we insist to do we want to be the host again. In the June 11 and 12 of 2021. So I would like to invite everybody to join this meeting. Please email me, or you can contact your Bonds, and then we hope Bonds will be our sponsor as well. Thank you very much for the time. I would like to thanks again for Bonds for inviting me for this wonderful meeting. Thank you.
Thank you very much, Dr. Hussein. Thank you for the wonderful presentation and for the invitation. So the next presentation is mine, and I will tell you about far out syndrome. So even few years ago, I even didn't know about this pathology and far out syndrome. And now I have a lot of patients, maybe 2 or 3 in months, which I have a surgery with this pathology. So there is a lot of patient who is walking between the doctors one to another, and everyone who watching the MRI, they say, yeah, it's okay, no intracanal compression. So they suffer from the pain and watching for another doctor who can relieve their pain. So what is far out syndrome? Far out syndrome is a compression and entrapment of the L5 nerve root in the extraforaminal area between the hypertrophied L5 transverse processor and the sacral ala. So it first was described in 1983 by the Wills and other doctors, and they describe it like a degenerative deformity in elderly patients and young adults with isthmic cholestasis more than 2nd degree. And this is irritation of the mostly it's L5 root, but sometimes when we have lumbarization or sacralization of the last lumbar vertebra, so we can have another irritation of another nerve. So the epidemiologists show us that the syndrome is one of the manifestations of lumbosacral transitional vertebra, which is seen is from 4 to 30% of adult population. The classification: the lumbosacral transitional vertebra was classified in 4 types. Type 1, L5 transverse process. Type 2 to 4 are associated with the pseudoarticular between L5 processor and the sacral ala or the iliac bone. Degenerative change leading to the facet arthrodesis and extraforaminal compression of the L5 nerve root. The concomitant significant pathology which we can find in these patients, this is disc herniation, disc ossification, ligamentum flava hypertrophy, facet hypertrophy, and some pedicle osteophytes. So what do we need for diagnosis? The most useful is CT scan, but sometimes we need MRI and imaging. So in this case, you can see that ossificated disc herniation, and if you go more lateral, we can see the irritation between irritation of L5 nerve by the transverse process of L5. So this the case is also with the irritation of L5 root with the osteophytes in this area. So what is the treatment? We always start with the treatments of nesteroid and anti-inflammatory drugs. Physiotherapy are also useful. Sometimes we use epidural steroid injection, and then if nothing relieves the pain, we suggest the surgery. The most useful in this case is transforaminal nerve root steroid block. So we use in this case dexamethasone and local anesthetics such as lidocaine to remove the inflammatory of this nerve root. So if the patient feel great after this procedure, they don't need a surgery. If not, we use a surgery. So Wills in 1984 suggest us to make the big decompression, open decompression with the removal of lower part of lamina, pedicula, TP, and part of the S1 body. But in these cases, it could be the instability, and without any stabilization, the patients will suffer the pain more than before. So you can use in these cases with open surgery transpedicular fixation, or use the UBE in these cases. About advantages of UBE, you heard a lot of in this conference. I will not stop on this. And in the case of far out syndrome, we always use dorsolateral or transforaminal approach. So how we count where we have to do entry point? We found a pedicular, extra lateral pedicular line. Over this line, we move 2 centimeters lateral. If it's obese patients, we can make incisions 3 or 4 centimeters lateral. And the second incision is 2 centimeters cranial from the first one. This is on the right side, if to count. It looks on the skin before the operations, you can see here. So what we can find in the from the right position, we are moving lateral and found here is the TP, and here is the junction between TP and sacral lateral mass. So what we have to do, we have to destroy this part of the joint and remove part about the 1 centimeter of transverse process. It's always deep, and you should be ready to remove maybe 1.5 to 2 centimeters deep. You should remove all the joint. So step by step, you use the bore or chisels to remove this part of the joint. So first you have to do to find this joint, and then step by step you have to remove it. After we use drains, so in our experience, we have the present of our patients is in this picture. So we almost in more than 60% of cases we have good and excellent result. Just a little we have a poor and fair result. Some complications we have when we suffer dorsal root ganglion, and the patients have an neuropathic pain, which we stop with the pregabalins in 1 or 2 months. So conclusion, the unilateral extraforaminal entrapment of the L5 nerve root may be successfully decompressed by UBE. UBE approach may be considered as an alternative for endoscopic decompression of far out syndrome. Minimal soft tissue dissection, minimal blood loss, excellent magnificence and visualization of the pathology are advantages of this procedure. And for Russian-speaking auditory, I want to invite you today to the satellite symposium about discogenic lumbar pain syndrome. With this, you can follow this link, and I will tell you about these cases. So thank you very much, and I am as the host. I want to introduce you next speaker. So the next speaker will be Karim Maxim Shalali from France.